do everyone go home with a baby?
That all patients we do IVF, are they getting pregnant? No. So that's the challenge, and the challenge is because we have not yet reached 100% success rate.
Recurrent implantation failure is a common phenomena in the IVF clinic.
So that means in the first cycle when you did not get a good egg or an embryo, or it was genetically abnormal, so we don't have. Then we have to go for cycle B and then cycle C. So the question is, why did we do 3 cycles? Multiple pregnancy rates have gone down. Complications related to multiple pregnancies have gone down. We have ensured that elective single embryo transfer has given us singleton baby.
We know that genetic problems are higher in consanguineous marriage. Does the law here mandate the genetic screening?
The younger you are, the normal cells are more, abnormals are less. The more advanced you go, this whole thing reverses.
PCOS condition is rising, and WHO has also said that more and more younger women or teenagers are getting PCOS.
Why do some women have absolutely normal reserve like 6, 7, 8, 10 follicles? And why do some women have plentiful? Scientific talk should start as early as in the schools, in the colleges, and our young population should be aware of it.
Hello viewers, thank you for another episode of Fertility Insight with me. And today we have a wonderful doctor, Dr. Partha Das. Dr. Partha Das is practicing his IVF and fertility practice at the Orchid Fertility Center, Dubai. Before coming to Dubai, Dr. Partha has over 20 years of experience, and he has been trained at Jaslok Hospital in Mumbai in 2003, and later on he moved for master degree in Valencia, Spain on ART treatments, and after that he went for the reproductive medicine study further in the Kiel, Germany. And he also have been a visiting research person at University of Iowa in the US, and he has helped a lot of patients who are suffering from fertility issue, the PCOS and hormonal imbalance and fertility as per se general. And welcome, doctor.
Thank you so much. Thank you for having me here.
Yeah, thank you, Dr. Partha, for coming here. And today we are suffering from, WHO has mentioned that almost 20% or 18% of the population is suffering from infertility. And these infertility cases are going to rise further worldwide. And I was reading this data also from Dubai that the Dubai fertility currently, or UAE fertility currently is 1.6. What is typically causing this lower fertility? Because here the government does not have any campaign that don't make more babies.
Yes. So thank you so much for inviting me today. So as we all know, WHO, which is World Health Organization, has classified infertility as a disease of the reproductive system now. Or that means if somebody is not able to conceive and have a baby, so and there is a criteria for that. Less than 35 years, you have to try for 1 year. If not, you have to go to the doctor. And if you're more than 35 years, 6 months of trying, and then you have to go to the doctor. And for ladies who are couples who are past 39, 40 years of age, then there is no time limit. Immediately you have to seek attention. So infertility is on the rise. Why it is rising? Probably because of a lot of factors, the globalization, the demographic, the whole world has become one now. People are moving in and out, career aspects, educational aspects, and so on and so forth. Once upon a time, we did not have much, methodologies, to understand why somebody is not getting pregnant. But nowadays, we do have a little bit of simple tests that we can predict from before, that something like AMH, okay, my ovarian reserve is low, or my ovarian reserve is not low, my sperm count is less, or so on and so forth. And we are able to do a lot of diagnosis. Based on this, we are able to counsel our patients, and we are able to offer the right treatment. So yes, having said that, it is not only in Dubai. Dubai is an amazing place when it comes to healthcare. It is one of the top-notch, healthcare destinations of the world, because we do everything with high standards of care. Fertility, infertility cases that we get to see here in Dubai, UAE, or any other parts of the world in US. I have my colleagues in Europe and US, and we have the same sad story to talk about, that we are seeing so many patients with infertility with different causes, male fertility causes, female fertility causes, combined causes. But yes, it is infertility. And the thing is, the narrative that what I would take an opportunity for on this platform is to educate the community that, don't take things lightly. Just get yourself evaluated as soon as possible, because the simple, clean statement is the earlier the better.
Okay, so the earlier the better. So the viewers, the bottom line is that the fertility, its infertility is a common. So don't take it that, oh, not me, on why he, or why not he. So if the WHO say around 18-20%, that means 1 in 6 or 1 in 5 is suffering from this issue. So it is very common. So better go and seek the doctor for treatment or evaluation, assessment.
Assessment.
Right.
So what we usually understand, and sometimes we human beings take ourselves for granted. All right. When I say for granted, means that I am slim and trim, and I am in the right BMI, and my skin glows, and I'm absolutely good. The man says I'm physically active. I do a lot of sports. I'm absolutely brilliant. Everything is under control. And my woman says, look at me. Everything's perfect. My menses are irregular. There is no problem. But that does not mean everything is good inside, because the external phenotypic presentation does not guarantee internal genotypic makeup. You understand? What I mean to say is our cellular changes in the body is very complicated. And when it comes to the reproductive cells, when I say talk about reproductive cells, means the sperm cells and the egg cells, they have a different story to say. Even if you are absolutely brilliant in the outside phenotypic, the way you look and conduct yourself, the inside quality issues can linger on, and that is about the quality of the eggs, the quality of the sperms, or abnormal genetics, or so, or other causes that can cause infertility. We have to understand that I am trying. I did not achieve my a success in few months of trying. I think there is something not right, and I need to go to the doctor and get evaluated. So these are the game changers, I think, which when it comes to reproductive medicine, this is what we need to think about.
Okay, so as the doctor you mentioned earlier, that if you are below 35 and 1 year you have not become pregnant and you are trying, go see a doctor. Something is not right. And if it is more than 35 and 6 months no pregnancy, please go see a doctor. Something is not right. Now, doctor, you said that slim trim, BMI is below 25, looking good. I have hairs in all the hairs are there. My skin is good, hair quality is good. I'm sleeping okay. And Dubai, I have seen most people are very handsome and beautiful here. How often do you see that even all the phenotype is good and they have either the egg quality not okay and sperm quality not okay?
How often?
How
Every
often?
day. Every
Every.
day. Today morning, I started my clinic at 7:45, 8 o'clock in the morning, and I was late. But the thing is, I've been seeing, and the question is, why my follicle is not there? Why my follicle is not growing? Why did I not get an extra egg? Why my egg did not fertilize? Why my embryo did not make it to the day 5 blastocyst? Every day, this is the scenario in the clinic.
So if you have to percentify that out of 100, how many you see?
If I see 100 patients, 85 of them are in this group.
So viewers, 85% of people who are even slim and trim, perfectly gym going, beautiful, can do, let's say, 100 kg of squats or 50 kg of bench press, 100 kg of deadlift, still the fertility is a different matter, right?
Yeah.
Since you are a specialist in reproductive medicine, what typically is a cause of this kind of thing? What kind of treatment you are giving? Means 85% patients are happening. What do you typically see?
So see, I'm the medical director at Orchid Fertility Clinic, all right? And ours is a tertiary fertility care center. So, when we get to see our patients, these are all the patients who has already done all the basic things. Now they have come for the end thing of, of opinions, of second opinions, or, treatments. So that means in our assisted reproductive program, we do things like artificial insemination when basic parameters are okay, or we definitely have to do in vitro fertilization program, which is IVF, as we all know. Most of the times we do the chromosome testing of the embryos, which is the PGT testing and all. Why? To select the best embryos, to give them a good outcome, to improve your chances of implantation and pregnancy, and decrease the rates of miscarriage. So this is what science and technology in reproductive medicine offers you. That if you're not able to achieve a pregnancy, you have been trying for a long time, then based on whatever criteria you present, and if you are an eligible candidate to do an IVF program, a good stimulation with injections for 12 to 13 days, harvest the eggs, fertilize them with the sperms, culture the embryos till day 5. So we have improved a lot. We do not stick to day 3 anymore. We go to day 5 or day 6. And then once the embryos reaches to day 5 or day 6, then we do the biopsy. What we say is the pre-implantation genetic testing of the embryos for aneuploidy to select the normal from the abnormal ones. And in case the report comes as a normal embryo, then at a subsequent cycle, not in the same cycle, we put that embryo back, hoping and praying that the lady ends up with 65 to 70% chances of positive pregnancy test. So what did we do with this? We selected the eggs, we selected the sperms, we made an embryo, we checked the embryo that it is normal like you and me, and then we put that inside. So her chances goes up to 60-70%. And miscarriages, as we all know, is first and foremost because of chromosomal error. So we have checked the chromosomes. So the miscarriage rate, I would not say it's nil, but it's negligibly quite low down. So this is the way we try to achieve our success with our patients. But unfortunately, that all patients we do IVF, are they getting pregnant? No, there are a lot of other, that 70%. So there is another 30 to 35, 40% who are not getting pregnant. So we again have to do things in a different way, with a different approach. And then we achieve another 30-40% pregnancy in that group. But we are left with again another 5 to 10%, who are still trying and struggling. So that's the challenge. And the challenge is because in our fertility medicine, we have not yet reached 100% success rate.
So let's say you said that not everyone is getting, and some patients are again trying. Let's say 3 cycle, a patient is trying fertility treatment, IVF treatment. Do everyone go home with a baby?
I will rephrase your question. You're saying that if somebody does 3 cycles of IVF, will everybody who does 3 cycles have a baby? No. But the chances becomes much better.
Means from initial 70-65%, it can go higher.
Yeah. So the question is, why did we do 3 cycles?
Yeah. Why do we need 3
Why
cycles?
did you do 3 cycles? So that means in the first cycle when you did not get a good egg or an embryo, or it was genetically abnormal. So we don't have. Then we have to go for cycle B and then cycle C, and to achieve a good embryo. And in case we end up with an embryo, we are actually doing repeated cycles to get a normal embryo, mind you. Why are we doing more than 1 cycle of an IVF? It is just to get that good normal embryo, or maybe 2, so that our chances becomes much better.
But the recurrent implantation failure is a common phenomena in the IVF clinic. So do you also see recurrent implantation failure in your clinic?
Yes, absolutely. I mean, that is our enemy actually, we don't like that. But what do we do? I mean, when we have recurrent implantation failure, so that means, so you take a step back and then you want to analyze this whole situation, that why did it happen? Means today we have taken our treatment to the genetic testing of the embryo. So that means I have put a very good embryo inside, but still the uterus rejected it. So that means the endometrial and embryo talk did not happen. That receptor latching of the embryo to the endometrium did not happen. Why did it not happen? Is there something in the uterus which is preventing it? Or is the mother's body producing some abnormal cytotoxic T cells, which is the immune dysfunction, immune dysregulation in the mother's body, which is rejecting that embryo? You understand? So then we have to open up that door and then try to do a lot of thing and a lot of evaluations, and then we do the immune modulation treatment, and then we end up getting successful outcome. In fact, today when I was the last patient which I saw, she had 3-4 miscarriages, and then she did IVF with us, and then we managed to get 2 embryos. We put 1 embryo, but before I put 1 embryo, I did her immune, and she had a lot of cytotoxic T cells, very, very high TNF alpha, and immune dysregulations in the body. And probably that was the reason that those cells were not letting a life grow there. So we ended up giving her immune modulations in the form of steroids and IVIG immunoglobulins. And as of today, I saw a heartbeat of 110
congratulations.
at 6 weeks. And see, when I showed the heartbeat, they were both silent, husband and wife. And we were all silent in that room. But it was a moment of happiness, but we were silent because they did not see this before. You understand? And today they saw this. Now, though it is a day of happiness, but I think they have gone home with a lot of scared thing that what if this heartbeat disappears in another 2-3 weeks? That fear is always there. So our immune modulation treatment is continuing. We are reassuring them. We will keep a close watch on them, and I am sure she will pass through this critical phase. So this is what we do. So it's, as they say, Rome was not built in a day. So in IVF, we cannot do it in one day. So sometimes we need a little bit of 2, 3, 4 months, to reach to that goal.
Okay. So, doctor, you just mentioned that immunity was attacking. Means, can you elaborate further? Will this patient will have always this problem that her body is
No,
going to
no.
reject every eggs?
No, it is not like this. Immune dysfunction can happen at any event of our life. The typical thing you must have heard about rheumatoid arthritis, where our own joint cells, the things attacks the joints and cartilages, and you have arthritis and so on
Even
and so forth.
the diabetes.
Diabetes and even thyroid, Hashimoto's thyroiditis, so many things are there. So likewise, you have a lot of toxic cells in our body, which builds up in our body and attacks specifically the growing cells, and that is the sperm cells, egg cells, all the embryo cells. Why it happens, we don't know. We don't want to know because it's a huge world of the unknown. We don't want to waste our time. But how we can tackle those cells, we know that. And we do that, and we have achieved a success.
Thus, this autoimmune thing will also happen to the sperm side.
Yeah, it can happen, but because of IVF, we have escalated the issue, so we have bypassed that. So we don't, it doesn't happen.
You don't see that
because that's become a thing of the past now.
Okay, so in part it used to be the case.
Yeah, exactly.
Now the patient coming to you and PCOS condition, PCOS condition is rising, and WHO has also said that more and more younger women or teenagers are getting PCOS. What are the treatment plans you have for PCOS, and how a mother or a parent can help their female child?
Polycystic ovarian syndrome, it is a very enigmatic, very stressful, situation for the girl and the woman. It happens. It's very common in the society. So we have to go beyond PCOS now. PCOS is the final endpoint. The question is, why do some women have absolutely normal reserve, like 6, 7, 8, 10 follicles? Why do some women have only 2, 3 and they have diminished reserve? And why do some women have plentiful? This answer we have not been able to understand, that why do some people have like this and why do some women have PCOS. We cannot change it, but with PCOS, they have understood a lot of genetic variations, because it has been shown that PCOS can run in families also. And if you understand those things, the much better. Nowadays, when we talk about evaluations, we are always encouraging that this kind of talk about eggs and PCOS and the outcomes should be started in school.
In the school.
In the school, you should know that what this physiology mean. All right, because at the end of the time, from the time a girl is 13, 12, 13 years and she gets her menarche until her menopausal state, during that time she will be having around 400, 500 ovulations, right? The big chunk of that thing is reproduction. Okay? It's the baby making function, all right? And the other one is the menstrual function. Now, because of this problem, either with a diminished reserve where you have very less follicles, or when you have excess, where you have too much of follicles like PCOS, they can hamper fertility. So the good talk that one needs to tell this group of people is that this is the physiology. Early intervention and early checking helps. And what are those early checks? Like basic hormonal profiling, a check of anti-Mullerian hormone. Because when you do a check of AMH and suppose that number comes as 7, 8, 9, so that means it is on the higher side. All right. If it is 0.1, 0.8, 1.2, that means it is on the lower side. So the cutoff margin is around 2. So in and around 2, it's good. So in case you have a report saying 7, 8, 9, automatically in your head, you have to understand that I am somebody who has a lot of follicles, which means that I might be ending up with a lot of hormonal problems, which means that my menstrual functions can get disorganized, which means that because of my high hormonal functions, I'll have those features of obesity and the acne, the fine hairs over my face. hypertension, my menstrual functions can go bad, my skin can change, colors can change because of this insulin resistance and all, which is called acanthosis nigricans, and so on and so forth. When you know all these things and when you are in touch with your doctor, then they regulate you well with, pills and, lifestyle changes, modifications, and all these other things. And always with a note that once you embark on your fertility journey, be mindful about this whole process. Don't ignore it. And the faster you finish your baby making process, the much better. And the same concept also to the people who have got diminished, because now, because your AMH is on the lower side, so that means you have got less number of follicles and you are a young age. So what is going to happen? Will I have my own baby or not? So that opens up the concept of egg freezing. So can I take these young eggs and keep it in the freezer so that I can go on with my career and my education? And I will continue trying myself to get a baby. But if I fail, then I can come back always to these young eggs and get my own baby. So this kind of talk, scientific talk, should start as early as in the schools, in the colleges, and our young population should be aware of it.
But do the school and colleges are doing this?
That is a legalization which should come from the government aspect and all, so that is an educational aspect of lawmakers, what they say, the law changes. But we as scientific people, I think we have to start talking about it.
So doctor, you well said that the law should take it over and then they should do the better job. Now you are a director at your Orchid Fertility Clinic, so you decide what kind of plan or treatment plan. So if a patient coming to you, a couple coming to you, what are the basic comprehensive test plan you have for female and for male?
Yeah, nice question. So as a part of the evaluation for a female who comes to us, we start, first of all, we do this extensive counseling and a talk like the way we are doing today. Everything from A to Z, what it means, and if I do this, what it means, if I don't do this, what it means. So the evaluation is in form of an ultrasound scan, which means that we do a pelvic scan to see how the uterus is, make sure there is no cyst, no polyps, no adenomyosis, and fibroids and all these other things. We see the ovaries also to see how many follicles she has for that cycle. So we count the number of follicles, which is called the antral follicular count. Because if the follicle count is in the range of 12 to 14, then we say that yes, it is all good by scan. And we also then conduct a tubal patency test, which is called the tube test, to check whether the fallopian tubes are open or not. So these are the invasive ones. Then comes the hormonal profiling, where you have a battery of hormones, the thyroids, the prolactins, the vitamin Ds, FSH, follicle stimulating hormone, LH luteinizing hormone, anti-Mullerian hormone, AMH, and so on and so forth. Of course, the sugar levels and all these things we check. So that completes the story for the lady. And for the man, of course, we do a sperm analysis test to check for the count, motility, and the morphology. And on a need basis, we also do a culture sensitivity, because sometimes there are a lot of men with hidden infections. They don't even know about it. And when we do a culture, we see a lot of pus cells, and then we have to give them antibiotics. And depending on a case-to-case basis, we then decide to do the DNA fragmentation test to see if the sperm is really, really good or indeed, broken into bits and pieces. So, and of course, if any kind of challenges are there in any of these evaluations, specifically for the man, then we subject them for an ultrasound of the testis and scrotum to check out if there is any anatomical problems like varicocele and all. Yes.
So how often you see this varicocele problem in your clinic?
So, see, all men have varicocele, all right? If you take random 100 people from the street, they will have a varicocele. But the thing is, are they clinically, diagnostic, which is causing the problem? That depends upon a lot of. You have to then step back and see how did the couple behave? Like, what is his sperm count, motility, morphology? If the morphology is very poor and they have had negative outcomes in fertility, like, they did an IVF, the embryos were not forming, poor quality embryos or something like that, or failed fertilization, and on clinical evaluation, it shows that there is a palpable varicocele out there on a severe variety, then we have to start talking about, the varicocele and the way we want to address that issue. It's a debatable, topic to do or not to do the surgery. I would say the question is how often you say. I would say in a month, maybe one or two, kind of varicocele. Yeah, one or two. Because as I said, one or two to do the treatment. I mean, there are many men with varicocele, we don't even do anything, because
Okay. Do you inform them that you have varicocele, or
of
is not
course,
needed?
of course. I mean, nothing goes without informing, right? We have to talk to our patients and everything. Even if I'm sneezing 100 times, and then that could be a problem. I have to tell that it is because of this. So varicocele is a very important diagnostic criteria in the evaluation of a fertility program. So yes, before anything that we find not good, we have to tell them that, listen, you have this anatomical problem out there, and this is the thing, and I think it's better you see our endocrinologist once for a complete check, and then we have to decide whether you really need to do a surgical procedure and rectify that problem.
So now you mentioned about the surgical procedure, and now we are in this area of Middle East, where you are getting the patient from the countries which are more patriarchal in nature. And now, when you tell the patient that, friend, your treatment may need varicocelectomy, the surgery, how open they are with the treatment?
Nice question. So when we talk to our couples and our patients, we do not want to know from what background you're going to come from. In that room, it is a complete scientific talk, a talk about good health, a talk about good diagnosis, and a talk about good treatment. We put in a platter in front of them that this is the problem and these are the solutions that we have for you. It is recommended that if you do this, maybe your chances can be better. I'm using the word maybe because fertility is a branch where we just know 50%. The remaining 50% we don't know. So basically, we are hitting in the dark. So we have to talk to them and we have to counsel them that this is your diagnosis, this is the issue, the decision is yours. So everybody is discussed. We do not get into the mode if they have whatever background they come from, whatever they have their beliefs, that is at a personal level. Maybe they will say, the doc, thank you so much. You have explained to us good, but we have decided not to do it. That's it. We document it, that it was spoken to them. The couple decides not to do it. We respect it. I've seen patients like this. And when we have counseled, they disappeared. And then they come back again after 8 months, 1 year. Like, I think you told the right thing. I think I'm ready to do it. So they change. So you know what? All these things that we find in our society and in our lives, it's all a mind game. You understand? So, what is a rejection today is an acceptance tomorrow.
But doctor, the although this varicocelectomy is debatable and WHO has not yet approved it as a first line of treatment, but the research shows that the male who has gone through the varicocelectomy, who had a semen quality problem, 60-65% are able to improve their semen quality and able to become the parent, even the natural process. Now, varicocelectomy process is a very simple one, and when the male say that no, I do not want to go for it, and then the women have to, and in your heart that this could have helped this couple, this could have saved the woman go through the multiple cycles of the pregnancy IVF process. How does it affect your whole treatment plan? Do you feel frustrated, or you resort to, okay, no problem, I have to go with another plan?
No, as I said, it is very clear actually. So we continue doing our IVF. The report card is in front of you. What is the report card? That I did a cycle of IVF, my sperm quality wasn't that great. In spite of taking all precautions. When I say precautions, means good lifestyle changes, you've taken supplements, and we have done the special techniques in the lab, the sorting things that we do. In spite of that, we have not got. And we know that there is a varicocele. The report card is in front of them. We cannot prove that it is because of the varicocele and the sperm bad quality it has happened, but it is one of the major criteria. Maybe egg quality is bad. We don't know. So we open it. We dissect the whole problem into multiple segments and in front of them. So many patients like, okay, I will not do it. Let me again try once and see for myself. If again in the second cycle it is the same repetition, Then we say that it's better now, before we do the third cycle, let's do something different. And why don't you just remove your varicocele, come back after 3 months, because you need 3 months wait, right? And then and they do it, and we go for it. I had a patient the other day who did cycle one in another country outside, and then she came to Dubai. She did cycle second or third with me. In the first cycle, we didn't get any embryo. It failed fertilization. It went up to day 5, day 6, and she didn't get. And then husband sperm was 2% morphology. So
Only,
yeah, so we said, okay, I mean, if you want to get checked, let's check it. And they were like, we want to do it, and whether it is mild, we want to do it, just get it done. So we did the varicocele surgery, and we did all these other things. In the second cycle, when we were doing and we also do the testicular aspiration of sperms. So when we were doing the varicocele, so to just get a little bit of from the testicle extractant. But again, knowing very well that testicular sperms sometimes can, be not
may not be
great.
good quality.
So before we took him inside, we told, give an ejaculate also, fresh sample. So we had all these options, but as it was, the testicular sperms was not that great, and we had to do the ejaculate sperms. Okay, and she made a beautiful blastocyst.
So from the ejaculate sperm.
From the ejaculate sperms.
Okay.
But we went ahead and did the varicocele surgery. So you see, I mean, what is right, what is not right, it is very difficult for us to understand. But a problem is there. We have to discuss the problem, and then we have to, offer it to our patients. Not in the first go, mind you. Again, I said, so many people have varicocele, but we do not jump into rectifying that. Only and only when we have a difficult trajectory of an IVF treatment that they have done before, not good quality, not good of embryos, failed fertilization, and so many other factors. And on the evaluation, man has got a very, clinically palpable severe degree of varicocele. Then I would say yes. I mean, get rectified and see for yourself. It's a simple surgery. It can give you, and once it is rectified, your chances of natural conception also goes up. So in all ways, you win this game. So yeah, I mean, people who understand the science, they do it.
So that is good. So doctor, you are explaining things pretty well. Now, to a normal viewer who is planning for an IVF, who doesn't understand the whole IVF process, so would you like to tell the stepwise what happened to the women's side and the men's side with the day, and take, let's say, their menstruation start as a day?
We have consulted a couple, and we have discussed that we're going to start the IVF program. So the lady is advised to see us on her menstrual cycle day 2, the beginning, not the end. Because many people think that, it is the day 2 of my end of the cycle, which means it will be, if somebody has got a 5-day cycle, she has to come on day 7, then you're not eligible. You have to come on the beginning. So if today the menstrual cycle starts, then you have to see me tomorrow. All right. So you have seen us today on day 2. And then we do the evaluation, that is by doing a vaginal scan. And then we do hormonal testing. And if everything is good, means there is no cyst, hormones are baseline, we start the injections. Now, injections we start based on a lot of criteria, based on previous history. From the day 2, yes. From cycle day 2, we start the injections. There's a subcutaneous injections which goes on the belly of the skin of the tummy, right? That's for 12 to 13 days, all right? So people get scared that, oh my God, I have to take injections for 12 to 13 days. So that's when I tell my patients that, what about our grandparents and all who takes insulin shots for diabetes? So if they can do it, then...
So what is the needle size?
It's a small, the subcutaneous needle, yeah.
Something like the vaccine we took, the COVID vaccine.
Exactly, similar.
Very,
same
very,
shot.
very, very
exactly.
fine needle.
Very fine needle. It is very, very, it's... the size is almost, it just goes under the skin, at the
so is it with the self-injectables?
Yeah, we have. Nowadays, the pharmaceutical companies have the pens, where everything is, pre-filled. You have to just press it and the needle goes inside and, you take the shot. So those injections starts from cycle day 2 and continues for the next 12 to 13 days. Within this 12 to 13 days, we will be subjecting the woman for scans maybe around 3 to 4 times.
3 to 4 times. Why you need to do the scan?
Why? Because we have to see the follicles growing, right? So we have given the purpose is we gave injections. Why did we give injections? To get your follicles growing. So we need to know how many follicles are growing, whether they're responding to the dose I gave. If the follicles are not growing appropriately, then I have to change your dose. Maybe I have to increase your dose. Or if I see that the follicles are growing very fast and too many, then I have to reduce your dose. So it's basically, now today's fertility treatment has become very individualized and very personalized.
Personalized.
We do not go by books and protocols. We go by individualization. Means what is right for you, we do it for you. It's not that I have to do it the same for the other person. So we individualize only by this process of calling the patients 3-4 times, keeping a very close watch on the hormones. We do the scans, and that takes us for 12 to 13 days. Once after 12 to 13 days, we
Means day 12.
12 to 13 days of injections, which is day 13 or 14 of your period. And then we will do the egg harvesting procedure. All right. Egg harvesting procedure. It is done under a short anesthesia.
Local anesthesia?
No local anesthesia. Short propofol IV injections where the patient goes to complete sleep, lasting for 30 minutes. And then within 2 to 3 hours, the patient goes back home. All right. So within during this 30 minutes, we
So when you extract this egg in the day 12 with a short IV injection with anesthesia, will the patient get cut?
No. Everything is transvaginal.
It's from the vagina.
Yeah, it is
There
a
is no
transvaginal
cut in the
approach. No,
body.
everything in our fertility is TVS, transvaginal
Okay,
approach.
okay.
Nothing abdominally, until and unless you have uterus literally up there because of adenomyosis and fibroids. But otherwise, everything is vaginal scans, vaginal procedures. Hardly a little bit of a brown spotting and all discomfort after their collection, and after that they go back home and they can resume back their normal life within the next after the same evening or the next day. Yeah.
So after the day 13 egg extraction, the women don't have to take hormone.
They do not have to take hormones. And on the day of egg collection, when the wife is doing the procedure on one side in the OT, the husband on the other side is collecting his sperms.
Okay, so the husband has to give the sperm
on the day of
12,
egg
the
collection.
13, yeah.
Yes. So when we get the eggs, then the sperms are ready, and then for every good egg that we get, we inject one sperm inside the egg, and that process is called ICSI. Intracytoplasmic sperm injection, all right, where we put one sperm inside the egg. So what was supposed to happen in the fallopian tube, the normal fertilization, we are doing it in the lab. So that is why it's called in vitro fertilization. We are fertilizing outside your body, and it is getting fertilized in the lab. And once the egg collection is done, the couple goes back home. They don't have to come to the clinic, but we are talking to the couple every day for the next 5-6 days, updating them about their status of eggs, the embryos that we got, what is the fertilization, and until we reach to the day 5. Once we reach to day 5, and if they have opted to do the genetic screening biopsy of the embryos, then we do the biopsy, we freeze that embryo, and then we have to wait for the reports to come in. And if the report says that you have a nice normal embryo, then we start planning for the transfer.
So in the next cycle, not in the same
Depends.
cycle.
Next cycle, some people say that I want to go for a tour. Can I come back after 3 months? So now once the embryos are in the freezer, we can freeze it. Like in UAE, the law is you can keep for 5 years.
Okay.
All right.
So now, so you mentioned, right, you have to do, if you are doing a genetic screening, then you do not get the result on the same day.
Yes.
So that means that cycle, you cannot do the
So that
IVF.
is the advancements of our fertility practice. We do not do IVF. We do not complete IVF in the same sitting. Nowadays, it is called stratified IVF, where we do cycle 1, only egg collection and making your embryos, freeze the embryos. And then again, you come back after a month or 2 or 3, whenever you want to come in for the transfer. So it is done into 2 different cycles.
So is the genetic screening is mandatory in Dubai?
No, there is nothing called mandatory. Okay. It is based on what we want. All right. So in Dubai, we have the ability to do the pre-implantation genetic screening of the embryos to know the chromosomal, the makeup of the embryo, like, whether they are having a gain or a loss of chromosome. When you say, like you and me, we are made up of one strand of chromosome from our dad and mom, right? And that's what makes us. But if you have only one strand, then it is a loss of a chromosome. Or if you have a gain, like it's trisomy, like a Down syndrome, then it's an abnormal chromosome, right? So we need to have 2. So we check those chromosomes to ensure that the embryo is normal. Now, the question is, couple says, but we are normal, then why should our embryos be abnormal? So we human beings are the most abnormal species in this planet world, unlike the animal world. Okay, we make a lot of abnormal cells in our body, and abnormality is there in every age group. Okay, the younger you are, the normal cells are more, abnormals are less. The more advanced you go, this whole thing reverses. The abnormal cells go up and the normal cells go down. But we do make. So once upon a time, when we used to do IVF, we just used to make embryos, and we didn't know whether this embryo was good or no good because we didn't do any testing. So we used to put 2, 3, 4 embryos. As a result of which, you used to end up with twins and triplets.
So nowadays you don't do.
Nowadays, we put only one single embryo. So as a result, our multiple pregnancy rates have gone down. Complications related to multiple pregnancies have gone down. We have ensured that elective single embryo transfer has given us singleton baby. And when we have more embryos in the freezer, these are the couple who come back after 2, 3 years and to try this. So somebody who has done this procedure, let's say at 34 years of age, and they got a baby at 34, she can come back at 37, 38 and use her and get a second baby using a 34-year-old embryo because you froze it at that time. You understand? So these are the advancements that we do in our, in UAE, in Dubai, and also, of course, globally around the world.
So doctor, you have stayed in multiple countries, right? And in Dubai, this particular place, the consanguineous marriages are also in high, and we know that genetic problems are higher in consanguineous marriage. Does the law here mandate the genetic screening?
So yes, when you come from that background of consanguineous marriage and all, of course, all those carrier screenings and tests are there, and people do try actually sometimes to get pregnant on their own, and sometimes they get good normal pregnancy, but sometimes when they get pregnant and they miscarry. And when we see the history that there is indeed a history of consanguinity thing, that we always have to ensure that all these checks are done, and then we advise them to go through a normal course of IVF with the PGTA, or then we can do the PGTM, like, to select the specific genetic mutation and eliminate that and then put a normal embryo inside.
Okay, so that is the great thing. Now, you have worked in Germany and US, India, many places. Thus, the law here is more providing more patient safety. Does it affecting your way of treating them? Means if you are treating the patient in another country, are you more free to choose the treatment plan in UAE, or you prefer the patient safety more than the treatment plans?
If I were given a chance again in my next life, to which part of the world would you like to practice your healthcare, and even if I'm a doctor, then of course I would select UAE and Dubai, because of its amazing healthcare infrastructure. Having said that, why not the other parts of the world? Because of so much of controlled regulations, like places are there where the genetic screenings are not done, or they are banned, or it's a red flag. So we have a lot of patients coming from Germany and Europe, UK, of course in US. They come and experience us, and they say that I wish our
genetic screening is done.
our this kind of an approach is there in our country also, and so what are we doing things differently? We have a very open approach. We are not restricted. Yes, in this country, because of the Shariat law and Islamic law, we do not do third-party reproduction. Means we do not do donor eggs, we do not do donor sperms. But self-IVF with the gametes of the husband and wife, and then we can do anything within that perimeter of what we can do as a fertility practice. Keeping in mind that any treatment that we do should not harm the health of our couples. So with that note, we can do everything, and we are doing it, and we are getting amazing results, and because of which I think this has spread far and wide, and we are having a lot of our patients coming from international countries only to come and say that I have heard you guys are doing all these things, and we want to come and experience UAE, Dubai, and also your healthcare. So I hope I have given
You have
answer
given
to your
a
question.
wonderful answer.
So we are not restricted by, as I said, by protocols and policies. We individualize and personalize our treatment, keeping in mind the regulations which you have in the country. Yes.
Yeah, so that is a wonderful that Dubai is a place where infrastructure is good, and you are enjoying this practice, and a lot of international patients are coming. And I do agree with you that even in Norway, this PGT, PGM and genetic screening are not done. As a result, the success rate of the patient, first of all, is not happening better way, and second, genetic disorders cases can be more there in those places. We had a wonderful talk on variety of topic, and we had Dr. Partha Das, who is a director at the Orchid Fertility Clinic in Dubai, with amazing infrastructure and labs and clinic and embryologists and the whole set of ecosystem. And I hope the viewers have understood the whole IVF process and many example cases. We took it over and lots of topic we covered. With this, I would like to thank Dr. Partha for coming and joining in this Fertility Insight and sharing the knowledge. Thank you,
Thank
Doctor.
you. Thank you so much. Thank you for having me here today.
Yeah.